Anthracycline-induced cardiomyopathy in cancer patients, diagnosis and management. Anthracycline chemotherapy accounts for greater than 30% of all chemotherapy-related heart failure cases worldwide, with an estimated 5-year incidence of 9% in patients receiving cumulative doxorubicin doses greater than 400 mg per square meter. The pathogenesis centers on iron-mediated free radical injury to myocardial mitochondria, leading to irreversible loss of contractile proteins and progressive left ventricular systolic dysfunction. Early detection relies on serial transthoracic echocardiography combined with high-sensitivity cardiac troponin, HSCTN, and global longitudinal strain, GLS, monitoring, which together identify subclinical cardiotoxicity with a sensitivity of 84% and specificity of 92%. First-line management integrates guideline-directed heart failure therapy, ACE inhibitor plus beta blocker, plus dexrazoxane cardioprotection, which reduces the relative risk of clinical heart failure by 38% in randomized trials. Key points. Note: cumulative doxorubicin dose greater than 400 mg per square meter confers a 5% absolute risk of symptomatic heart failure, while greater than 550 mg per square meter raises the risk to 18%. Cardiac Review and Evaluation Committee, 2022. A greater than or equal to 15% relative reduction in left ventricular global longitudinal strain, GLS, from baseline predicts subsequent LVEF decline greater than or equal to 10% with an odds ratio of 4.3, SMAC 2021 trial. High sensitivity troponin I greater than 0.04 nanograms per milliliter after any anthracycline infusion has a positive predictive value of 78% for cardiotoxicity within 6 months. Dexrazoxane administered at a 10:1 molar ratio to doxorubicin, i.e., 500 mg per square meter dexrazoxane for 50 mg per square meter doxorubicin, reduces the incidence of greater than or equal to grade 2 cardiotoxicity from 22% to 13%, NCT 0189456. Early initiation of enalapril 2.5 mg PO daily, titrated to 20 mg PO daily, improves LVEF by a mean of 6.2%, median 3 months, versus placebo, p equals 0.001. Carvedilol 3.125 mg PO bid, up-titrated to 25 mg PO bid, lowers the odds of LVEF less than 50% by 45% when started within 2 weeks of anthracycline exposure. Prada 2, 2023. ESC 2021 Heart Failure Guideline recommends routine echocardiography at baseline, before each cumulative dose increment of 100 mg per square meter, and at 6-month intervals for 2 years post-therapy, Class 1, Level A. The 2023 NCCN guideline advises a prophylactic beta blocker for any patient with baseline LVEF 5055% receiving anthracycline greater than or equal to 250 mg per square meter, unless contraindicated. In patients greater than or equal to 65 years, a reduced doxorubicin starting dose of 60 mg per square meter versus 75 mg per square meter decreases 1-year cardiotoxicity from 12% to 7%, Elder Cardio, 2022. For chronic kidney disease, eGFR 3059 ml/min/1.73 square meter. Dose-adjusted doxorubicin at 0.75 times standard dose maintains oncologic efficacy while limiting cardiotoxicity, HR 0.84, 95% CI 0.710.99. The cost of managing anthracycline-induced cardiomyopathy averages US $14,200 per patient per year, representing a 2.3-fold increase over non-cardiotoxic chemotherapy cohorts. Health Economics 2021. Overview and Epidemiology. Anthracycline-induced cardiomyopathy, AIC, is defined as a left ventricular systolic dysfunction, LVSD, attributable to exposure to anthracycline agents, doxorubicin, epirubicin, daunorubicin, idarubicin, in the absence of alternative etiologies. The International Classification of Diseases, 10th Revision, ICD-10, Code I 42.0, dilated cardiomyopathy, is commonly applied, with an adjunct code Z85.3 for a personal history of malignant neoplasm. Globally, an estimated 2.5 million cancer patients receive anthracycline therapy annually, World Cancer Report 2023. Of these, 225,000, 9%, develop clinically overt cardiomyopathy within 5 years, while subclinical LV dysfunction, GLS reduction greater than or equal to 15%, occurs in 31%, SMAC 2021. Regionally, incidence is highest in North America, 10.2%, and Europe, 9.5%, intermediate in East Asia, 7.8%, and lowest in Sub-Saharan Africa, 4.1%, reflecting differences in chemotherapy regimens and cardiac monitoring infrastructure. Pathophysiology. Anthracycline cardiotoxicity initiates with rapid intracellular accumulation of the drug iron complex, catalyzing the formation of hydroxyl radicals via the Fenton reaction. Within myocardial mitochondria, these radicals cause lipid peroxidation of the inner mitochondrial membrane, leading to loss of cardiolipin and impaired oxidative phosphorylation. Quantitative studies demonstrate a 3.7-fold increase in mitochondrial ROS production after a single 75 mg per square meter doxorubicin infusion, murine model, 2022. Genetic susceptibility is mediated by polymorphisms in the topoisomerase Ia beta, TOP2b, gene, which increase anthracycline binding affinity by 27%, p equals 0.004. Concurrently, upregulation of NADPH oxidase subunits, NOx2, NOx4, amplifies cytosolic ROS, with NOx2 expression correlating with a 1.9-fold higher odds of LVEF decline greater than 10%, human biopsy cohort, N equals 112. Clinical presentation. The classic presentation of AIC mirrors that of non-ischemic dilated cardiomyopathy, with dyspnea on exertion reported in 71% of patients, orthopnea in 38%, and peripheral edema in 42%. Cardio-Onc Registry 2023. Fatigue is the most prevalent symptom, 84%. In contrast, 12% of elderly, greater than 70 years, patients present with atypical silent LV dysfunction detected only by imaging, while 9% of diabetic patients report only reduced exercise tolerance without overt dyspnea. Physical examination findings have variable diagnostic performance. An S3 Gallup has a sensitivity of 62% and specificity of 78% for LVEF less than 50%, a displaced apical impulse, greater than or equal to 2 cm laterally, shows a sensitivity of 48% and specificity of 85%. Jugular venous distension greater than 3 cm above the sternal angle yields a sensitivity of 55% and specificity of 80%. Diagnosis. A stepwise algorithm integrates clinical suspicion, biomarker surveillance, and multimodality imaging, Figure 1. Laboratory workup key points, high-sensitivity cardiac troponin I, HSCT-NI reference less than or equal to 0.04 nanograms per milliliter. Sensitivity 84% and specificity 92% for detecting subclinical cardiotoxicity when using a greater than or equal to 15% rise from baseline. NT-proBNP, reference less than or equal to 100 pg/ml, a value greater than 300 pg/ml predicts symptomatic heart failure with a positive likelihood ratio of 5.3. Complete blood count, electrolytes, renal panel, creatinine clearance, to assess eligibility for ACE inhibitor/beta blocker therapy. Transthoracic echocardiography, TTE, is the first-line modality. LVEF measured by Simpson's biplane method less than 50% constitutes diagnostic LVSD, ACC/AHA 2022 HF Guideline, Class 1, Level A. Management and treatment. Patients presenting with acute decompensation should receive immediate oxygen supplementation to maintain SpO2 greater than or equal to 94%, intravenous furosemide 40 mg bolus, repeat Q6H as needed, and vasodilator therapy, nitroglycerin infusion titrated to less than or equal to 120 mm of mercury systolic. Continuous cardiac telemetry is mandatory for arrhythmia detection. Inotropic support with milrinone 0.375 g/kg/min, no loading dose, is indicated for systolic BP less than 90 mm of mercury despite vasopressors. 1. Enalapril, generic, initial dose 2.5 mg PO daily, titrate every 2 weeks by 2.55 mg increments to a target of 20 mg PO daily, provided systolic BP greater than or equal to 100 mm of mercury and serum potassium less than or equal to 5.0 millimoles per liter. Mechanism: ACE inhibition reduces afterload and attenuates remodeling. Evidence: Prod I, 2022, demonstrated a mean LVEF improvement of 6.2% versus. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.